Warm welcome, ladies and gentlemen. Critical care nursing is a super specialty in the domain of healthcare. There is great demand in competency building and talent acquisition for critical care nurses across the globe and more so in our own nation. This is going to be a great initiative from both ANI, that is Association of Nurse Executives India, and Critical Care Nurses Society, Tamil Nadu Chapter. And we're going to hold a whole lot of series throughout this year and a few months of next year too. We urge each of you who are here today to encourage your own colleagues and your nursing friends from other institutions to join in the subsequent series of uh, this webinar. It's my privilege today to welcome the presidents, the presidents of ANI and CCNS, that is Association of Nurse Executives India and Critical Care Nurses Society, the national level office bearers, chapter heads of both associations, the senior nursing leaders who are stalwarts and role models for us, Dr. Jyoti Clara, the Tamil Nadu guide and the all in all who keeps encouraging us, and she is our ex-vice president of ANI, and our own Tamil Nadu chapter office bearers. Welcome to each of you, Dr. Rachel ma'am, the vice president of the state, and Dhanalakshmi, the secretary of the state. Thank you for joining, and I welcome each and every one delegate who are present here today. We request all the participants to stay mute while the speakers present their topic, and request all of you to participate actively by questioning after the session gets over. You may also type in your questions in the chat box. Welcome each of you. She is an audacious speaker, versatile and courageous lady, nursing stalwart, seen her stand tall for placing her thoughts for nursing. Ladies and gentlemen, introducing to you the National President of Association of Nurse Executives India, Captain Ajita Nair. I invite you, madam, to address the gathering.
Thank you, Leena. I thought you were going to tell Rani Lakshmi Bai from your introduction. Thank you for those nice words. I would like to congratulate you, Leena, and the team of Tamil Nadu chapter for always being ahead of everybody else in organizing meaningful programs as part of the chapter activities throughout the year. Okay, this had been since the beginning, and I know that the force behind is Jyoti Clara. I know that too. And maybe somebody can admit these people because I had been doing that. Okay, so I would congratulate also Minimol and CCNS for participating in this and partnering with the Tamil Nadu team for, I guess this is going to be a series of critical care nursing webinars like this. I'm sure this will help all the participants, and you are recording it and it will be available for future reference also. And now we struggle actually to have enough of nursing training hours, and also what we all can do is that in all the institutions these recorded versions later also can be organized in a classroom, and it can be part of their training schedule, and even it can be planned as well once it is available in the public forum. And this will go a long way. Or you can even encourage people to see it at their own pace because it is available to everyone. But we all must ensure that it reaches all the nurses. So we do take a lot of efforts, I'm sure, at both the societies. But how much we are able to reach out to the length and breadth of the country with to reach nurse, I do not know this. And only that I know is that we have miles to go and a lot to do. So that would be my initial thoughts with this. And I would congratulate the speakers who are going to be there today. Ashwati, Mario, Chitra, and Mary Jansi. Mary Jansi probably has joined recently to ANEI. And I would be very happy to listen to you, Mary. And I have seen a lot of new members also participating in this. I have seen Perpetua joining, and Jessie Deben is waiting in the waiting room. Let me admit her. And very happy because these are members who are, hardly I do see. Jessie Deben has been member for I think 2 years, but she had come. So welcome all of you, in fact, to join this, and please spread the word. This is what I would say, everyone. Please spread the word about what good work ANEI is doing, and especially Tamil Nadu chapter. And let us, make such efforts to reach out to everybody. And just one parting comment: we are going to have our national conference on 26th and 27th at Hyderabad. And please spread the word around, make arrangements to come over there. That's going to be a great learning time for everybody and a great experience. We all are working for making it a memorable, great event. This is going to be our first national conference, which is physical conference, means in-person conference. And I would request all your cooperation in that as well. And welcome all of you to Hyderabad, and see you over there. Thank you, Leena, for this opportunity, and over to you. Thank you.
Thank you, Ajita ma'am. Next, I'm very, very happy to introduce Ms. Minimol Verghese, our new acquaintance, President, Critical Care Nurses Society, also the CNO. Sorry for that. Also the CNO of Fortis Hospital, Mulund. She's with 10 years of clinical and 18 years of administration experience. She's been instrumental in creating the critical care nursing standards. She's having a lot of awards and publications to her credit. Inviting you, ma'am, to address the delegates.
Thank you so much, Leena. And so what to say, good afternoon, everyone. So it's a great privilege for me today. I'm seeing Annie and CCNS coming together in this platform. And the idea is by one and only one person, which is Dr. Jyoti Clara, who is supported by Leena, and of course, Ajita, Madam Tangam, all are the pillar behind it. But to have this thought process, why can't we come together and have sessions like this to improve the knowledge of the nurses? Because today, the speakers whom are going to share, we have Mary Jansi, Ashwati, experts, Dr. Chitra, who was a principal in one of the great college in Mumbai, Mario, again 10 years of teaching experience, and he recently joined and came to our clinical. So experts talking, and so I know all the participants are going to benefit from this. And of course, Leena, so well you coordinated this event, and so it was smooth going, and you were following it up for everything. This shows the true leaders who want to uplift nursing in India. So many people talk, some people talk and make it into whatever they are talking, put it into practice. So these are the examples, people who are on the screen, we can see that. So for your dedication and your passion for nursing, and of course to change nursing in India, this is one of the steps where we reach out to the nurses who are may not be so much skilled in their organization, but to learn from such webinars. Thank you so much. And of course to thank Rachel, Dhanalakshmi and Mahalakshmi, who is coordinating with Leena to make this today's workshop a successful event. Thank you so much, and all the best to all the speakers. And thank you once again, Ajita, a pioneer in nursing, and of course to Dr. Jyoti Clara for such a thought process, and always there as a guide and as a mentor. Thank you so much, ma'am.
Thank you, Mini ma'am. We are going on to the scientific session. We have our first speaker of the day, Mrs. Chitra M. Nayak. She is professor and also the vice principal of KDA Nursing College, Mumbai. She is her alma mater is SNDT Women's University and LT College of Nursing. Has worked in capacities of being a lecturer, associate professor, and professor. Has been an advisor for Gujarat Public Service Commission. She is an executive member at the CCNS. She is also an executive member of Tharangan Alumni Association of SNDT. She's presented a lot of papers and has got a lot of publications. She's also been a speaker at many conferences. Happy to have Dr. Chitra with us presenting on the topic monitoring of ICU patients. Over to you, madam.
Good afternoon, everyone. I hope the screen is visible.
No, ma'am, not yet.
Not yet, not yet.
Okay.
For me, it is visible. Okay, not yet. It's gone.
Is it visible now?
It's coming. Yeah, yes. Please put it on the screen show.
Yeah, sure. Okay. Okay. Is it visible now?
Yes, very clear.
Okay. Yeah. Thank you, everyone. Today's my topic is monitoring the patients in intensive care units. The learning outcomes for this session would be at the end of the session. The participants would have a clear understanding about continuous cardiac monitoring, monitor the patients in intensive care units with hemodynamic monitoring and able to manage the troubleshooting, monitor neurological status of the patients in intensive care units and the general parameters. So the first we will begin with vital signs. In vital signs, first and foremost in intensive care unit, we have a continuous cardiac monitor, but in spite of that, to assess the patient's pulse is equally important. So the grading of the pulse palpation is 0 not palpable, 1 plus faintly palpable, 2 plus palpable, and 3 plus bounding. The heart rate monitoring we usually get on continuous cardiac monitoring, and the rhythm. Now, whenever we look at the rhythm, we should focus on whether it's a sinus rhythm or not. We should be able to identify if there is any PVCs, any arrhythmias that are happening. The PVC, if it is happening, 10 PVCs in 1 minute are considered to be very, very significant. So another important thing about PVCs is whether the PVC is multifocal or unifocal. So if it is unifocal, it is less severe, but if it is multifocal, it can be dangerous. Now, what do we mean by sinus rhythm exactly? Now, what the sinus rhythm means that the patient is having in lead 2 PQRST very much visible. The P is having a proper morphology, means normal morphology. PR interval is normal, QRST duration is normal, and it is normal in configuration. Then your ST segment is at equivocal line, and then your T morphology is normal. So if all these criteria are maintained and RR interval is regular, that means the person is in sinus rhythm. Next is cardiac monitoring. We usually have nowadays, we use 5 electrodes, or previously we had 3 electrodes. So some hospitals may have 3 electrodes monitoring and some may have 5 electrodes monitoring. The basic principle behind having a 3 electrode is just to monitor a single lead, but 5 electrode monitors help us to observe the 2 leads simultaneously. So most of the time, as per hospital policy, we can have lead 1 and lead V1, that is MCL1, or in some hospitals, we can have lead 2 and MCL. Now, especially in cardiac intensive care units, the patients who have come with infarcts or myocardial ischemia. So in such patients, the zone in which the patient is having a problem, like if it's an anterior wall, or whether it's an inferior wall, whether it is a lateral wall, MR. So based on that, we select the particular lead for observation. Otherwise, in most of the patients, we select lead 2 or lead 1 and V1 or MCL1. So accurate lead placement is very essential for accurate monitoring, and lead placement should be verified at the beginning of every shift by the assigned nurse. Now next I have taken is pulse oximetry. Now pulse oximetry is something, it's a non-invasive method. We all know that. It consists of microprocessor and a probe. Now it has a system where two light emitting diodes and photodetector is present. Now these two light emitting diodes emit basically two types of light, that is red and infrared light wavelengths, and they pass through the pulsating vasculature bed and they reach the photodetector, and this photodetector converts these light signals into electrical signals, which are then sent to microprocessor, and microprocessor is the one which converts it into the digital reading. This is considered to be highly accurate. Now, pulse oximetry can have two types of limitations, maximum physiological limitations as well as technical limitations. Now, in physiological limitations, if the person has abnormal HB, which is high, it can give you a false high reading. As well as if the patient has come from any investigation where the dye has been used, like methylene blue and all. So in this cases, it can give you false low reading. So these things are very important for a nurse to keep a note of. And third thing, if the probe is attached to an area or peripheral area where which is not adequately perfused, then we can get false low readings. And technical glitches that the person can have is like, if you're if you are caring for a patient in an area which has got two bright lights, it can interfere with this probes or this diodes, and the photodetector can sense it improperly, and we can have inappropriate readings. Then second thing, if patient is moving too much, then it can cause false readings. And third thing, if the probe is not selected properly, like you can see, we can have different probes for pulse oximetry, like finger probe, ear probe, toe probe, nose probe and all. So if the proper probe is not used, or if it is not placed properly, then we can have false readings in pulse oximetry. Next, we move on to hemodynamic monitoring. Now, basically, hemodynamic monitoring is divided into simple level and intense level. In simple level, we can have we have heart rhythm, CVP, and ABP. Whereas in intense level, we have PAP, cardiac output monitoring, and continuous measurement of pulmonary arterial oximeter saturation, that is called as SpO2. Now, whenever we use hemodynamic monitoring, we all know what kinds of equipment that we use. We use a pressure monitoring system. Now, in pressure monitoring system, when we have a pressure, a flush with the pressure bag, then that is attached to a pressure monitoring system and a catheter. Now, in this, the whole system needs to be calibrated. Now, in calibration, there are two things that are very important. One is called as zeroing, and second is called as leveling. Now, when we basically do zeroing, what we are exactly doing is the calibration of the system to the atmospheric pressure. So this atmospheric pressure has some influence on our means the pressures that we monitor. So we equalize the pressure inside the system and the atmosphere so that there is no error remaining. So that is what you mean by zeroing. And next is leveling. That is, we maintain the transducer at the phlebostatic axis. I hope everybody knows the phlebostatic axis. Next is Next, we move on to arterial blood pressure monitoring. Now, it is designed for continuous assessment of arterial perfusion of the major systems of the body. Now, mean arterial pressure is used to assess the perfusion pressure throughout the body. Mean arterial pressure can be calculated as 2 diastole into 1 systole upon 3. Now, MAP has to be more than 60 if we require adequate cardiac perfusion to be maintained. Okay. So for cardiac patients, we try and aim to maintain the MAP between 70 to 90 in intensive care unit. But whereas cerebral perfusion is concerned, the MAP has to be maintained between 90 to 100. Now, to increase the cerebral perfusion pressure, especially after endarterectomy and neurologic surgeries. Now, when cardiac output reduces, body compensates by constricting the peripheral vasculature in order to maintain the blood pressure within normal limits. Now, in this situation, MAP remains constant, but the pulse pressure narrows. So, most of the time, while monitoring the patient, MAP is not much focused, but pulse pressure can give you a lot of information, because in compensatory phase, when the peripheral vascular constriction happens, that time your systolic pressure increases, which narrows your pulse pressure, and that's how we will come to know before even MAP affects that the physiological, means there is a physiological decompensation happening. The narrowed pulse pressure and increased heart rate indicates hypovolemia, and MAP begins to decrease in case of decreased cardiac output. Next is arterial blood pressure waveform. This all of you all are aware about. Now, the first upstroke is nothing but a systole. Now, arterial waveform in ABP waveform, the first upstroke and the highest point is called as systolic peak. The point of your catheter facing the first valve, that is the aortic valve. Now, the waveform that we are going to get is of course of aortic valve. So the moment aortic valve opens, we get a upstroke, and that is called a systole. Afterwards, there is a ventricular relaxation happening, so the pressure starts falling, and the aortic valve closes, which gives a dicrotic notch, and there is a further diastolic runoff. So this is how arterial pressure waveform talks about. So the electrical stimulation always happens before the mechanical activity. So you will find, means if you try and correlate your ABP with ECG, you should find your systolic peak after your cure is complete. So that's the crux of it. The troubleshooting. Now the damped waveform. If the monitor shows low BP, we need to evaluate whether it is a true means whether it's a true problem or it's a problem with the equipment, means whether it's a physiological problem with the patient or problem with the equipment. In case of low arterial blood pressure waveform, the digital readout is correlated with the patient's own cuff pressure and confirm that the patient is having hypertension or not. This waveform is more rounded and without any dicrotic notch if it's a damped waveform. When the patient's BP is significantly higher than the digital reading, then it indicates that there is a problem with the equipment. So first of all, to differentiate, we have to counter check with the non-invasive method. So damped waveform occurs when there is an interruption in communication between the artery and the transducer. It may be due to the clot at the tip, or it may be because of the catheter kick. Next comes is the underdamped waveform. Now it is usually called overshoot or fling. Now this waveform has narrow systolic peak producing high systolic pressure when compared to cuff pressure. It can be caused by increase in dynamic response or increase in oscillations in the system. So in this problem, we need to do a square test. So whenever we do I have shown here the normal waveform, the damped waveform, and underdamped waveform. So if there is a problem with the system, then we have to perform a square test. So in this, we have to pull the flush the moment we pull the flush, we will get a square on the monitor. If the straight line that you can see on the square test, if there are oscillations, that means there are dynamics in the system. So we have to flush the system, zero it again, and then again do the square test and then confirm. Next comes CVP waveform. Now in CVP waveform, central venous pressure. The central venous pressure basically speaks about the right ventricular end diastolic pressure. In this, the A is the atrial contraction, X is the downslope, C is the tricuspid valve closure. There is a further relaxation of the atria. Then we have the atrial filling, and then the valve opens, and there is a further runoff in the rapid filling phase of the right ventricle. So this is how the CVP waveform looks like. Most of the time, we will not be able to see CV in the CVP waveform. Now, CVP accurately reflects right ventricular end diastolic pressure. See, if you try and relate, most of the time from like A to Y, if you see maximum time, the tricuspid valve is open. Okay, only from C till X fall, this is the time the valve is closed. And that's why we have a right ventricular end diastolic pressure, which is measured because means CVP basically measures the right ventricular end diastolic pressure. Now CVP is usually between 2 to 5 mmHg or 3 to 8 centimeters of water. Low CVP, the reduced end diastolic volume increases the heart rate to maintain the cardiac output. So CVP is used with MAP and other parameters to assess hemodynamic stability. If hypovolemia, CVP reduces first and then MAP. So CVP is a good indicator, especially in case of hypovolemia, which could be because of bleeding, vasodilation, patients on diuretics, patient being warmed after cardiac surgery. So in this cases, CVP is helps us to understand the patient's hemodynamic status better than MAP. High CVP, then increased CVP indicates increased volume, which can cause, which requires extra force to eject this volume and which increases the myocardial oxygen demand. It is not reliable to detect LV dysfunction as it increases the filling pressure on the left side. So left side problems cannot be measured with CVP. Next, for peripheral lines in intensive care unit, we usually use VIP score in our institute. So in this score ranges from 0 to 5. So here we have 0 as IV site appears healthy, whereas 1, in this one of the following is evident, that is slight pain near the IV site or slight redness. If there is pain near the IV site, erythema and swelling, any two parameters are present, then we score 2. Or like if pain along the path of the cannula, erythema and induration all are present, then we score 3. If pain along the path, erythema, induration and palpable venous cord is present, then we score it 4. And if the pain along path of cannula, erythema, induration and palpable venous cord and pyrexia, then we score it as 5. This indicates the advanced stage of thrombophlebitis. Next is the level of consciousness. As far as GCS is concerned, all of us know the GCS. Now the problem happens when the nurses go and perform GCS. And most of the time we have seen that they have problems in assessing motor response. So obey's command localizes pain. So in this, when we give instructions to the client to check whether client is able to follow the commands or not, that time you have to assess it bilaterally. Most of the time nurses perform it unilaterally. We have to differentiate in the patients who are neurologically impaired, means who are having a central nervous problem, and paralysis and paralyzed patients. So most of the time it is recommended that we need to do a pronator drift for upper extremities when we are assessing motor response of the patient. The next is localizes pain and withdrawal to pain. Now, when are you going to mark localizes pain and when are you going to mark withdrawal to pain? That matters the most. Usually, patient is not going to tell you that I am having a, means wherever you give a central stimuli, client is not going to tell you, okay, I have got a central stimuli here, but rather client will try and push away the stimulus. So that is called as localizes pain. We have found a lot of problems as far as nurses documenting GCS. So that's why I'm explaining this. Rest of the things you all know, that is abnormal flexion, abnormal extension. It depends upon when the increased ICP causing a pressure in which area of the brain. That will tell you, means the posturing will tell you where exactly the pressure would be. So the abnormal flexion, we give a score as 3, abnormal extension as 2, and no response. No response, it means that the pressure is exerted at the brainstem, and it is indicated by total flaccidity. In pediatric areas, we use GCS where the eye response is similar, but verbal response in this, there are changes, like coos and babbles normally is 5. The child is irritable and continuously crying is 4. Cries in pain is 3. Moans in pain is 2. And no response is 1. In order to see, ICP monitoring in intensive care unit is not done for each and every patient, but we have many neuro patients coming to intensive care in our intensive care unit. So we use this chart to understand where, in which phase of increased ICP, whether it's the client is in the compensatory phase or whether it's in a decompensation phase. So we have stage 1, stage 2, stage 3, stage 4, and death. So these are the 5 stages, and we try and monitor the patients with this type of a chart. So the parameters in this are mental status, pupils, breathing, blood pressure, pulse, and temperature. So in stage 1, the client is awake and alert. The pupils are equal and reactive. Breathing is normal. The blood pressure, the systolic and diastolic, is between 120 by 80. Pulse is also normal. Approximately somewhere 80, and the temperature is normal. In stage 2, the episodes of confusion and restlessness and lethargy occurs. Pupils are still equal and reactive. Breathing is normal, and blood pressure and pulse also do not have much of change. But in stage 3, most of the changes begin. That is, beginning inability to stay awake, continuing on to progressive deeper coma. Pupils, small reactive pupils progressing to slow response. Breathing normal, but may become slow, and may be progressing to chance stroke. The blood pressure is the systolic and diastolic. There is a widened pulse pressure, and pulse is full bounding, and surgical or medical interventions may be needed here. Stage 4, again, we check for pupillary response. Now the pupillary response over here, we will get a direct, we may get a direct response, but we may not get a indirect response to reaction to light. So this is what is very different in stage 4. So that's how this chart helps us to monitor the patient, neuro patients, whether they are going, means whether their ICP is increasing or not, and in which phase of increased ICP the patient is progressing. Next, in intensive care unit, many patients are on sedation. So we usually use the RAS, that is Richmond Agitation Sedation Scale. I hope all of you all know this scale. Okay, so I'm not explaining it in detail. Some of the institutes use modified Ramsey sedation score, but in our institute we go for we use Richmond Agitation Sedation Scale. So with this, I conclude my topic. If you have any doubts, you can ask.
Thank you so much, ma'am, for sharing your knowledge with us. This is Dhanlakshmi, Secretary of Tamil Nadu Nadu Chapter. And ma'am, I have given a detailed information of vital signs, continuous cardiac monitoring, pulse oximetry, and arterial blood pressure monitoring, troubleshooting waveform, monitoring peripheral IV monitoring, and level of consciousness and ICP monitoring, whatnot, monitoring sedation, importantly nursing management. Lovely description, ma'am. On the whole, ma'am, you created a mock ICU and forced us to keep an eye on it. So much appreciated, ma'am. Thank you so much, ma'am.
Thank you.
To talk about today's second speaker, Miss Mary Jansi. She is Assistant Professor, College of Nursing, CMC Vellore. Madam has completed MSc Nursing, BLS and ACLS trainer, has been the resource personnel for various workshops, published papers in national and international journals. To talk of, ma'am is going to discuss about understanding the modes of ventilator, role of nurse. So over to you, ma'am.
Good afternoon, everyone. I thank for the opportunity given for me to do this presentation. Today, we are going to have a discussion on understanding the modes in ventilator and the role of nurse while you are adjusting the modes in ventilator. The learning outcomes for today, at the end of the session, participants are able to define what is the mode in the ventilator and list the factors to be considered in choosing the mode of ventilation and differentiate between volume controlled and pressure controlled ventilation and set the ventilator settings appropriate to the mode of the ventilation. Discuss the role of nurse in caring for patients with various modes of ventilation and to prevent, identify and manage complications of mechanical ventilation. What is mode? So we would like to know what is mode, and it refers to how the machine ventilates the patient. Okay, so in other words, it has got the pattern of interaction between the patient and the ventilator. Okay, so what you're going to see is whether what is the interaction between the machine and the patient, whether the machine is going to have a complete control over the patient or whether the patient is not going to have any control by the patient, by the machine, or is there going to be some interaction by the machine as well as the patient. Okay, so in that aspect, we're going to see different modes of ventilator. Okay, so if you see on one end, when we see controlled mandatory ventilation, everything is done by the machine. On the other end, if you see, it is spontaneous mode. When we say spontaneous mode, everything is done by the patient. All the breath, the rate, volume, everything is determined by the patient. So we have on one hand controlled mandatory ventilation, on the other hand we have spontaneous mode. Okay, in between we have many modes where there is interaction between the patient as well as the machine. Okay, how much interaction, how much is by the machine and how much is by the patient. And factors to be considered while choosing the mode of ventilator. What mode of ventilation is more appropriate for a particular patient? It depends on the patient's participation in his ventilatory pattern, the patient's inspiratory effort, whether the patient is able to have spontaneous breathing. Okay, so the patient's participation in his ventilatory pattern and patient's condition, underlying disease condition, and what is the goal of treatment for the patient, and also to make sure that the patient gets adequate gas exchange and ability to synchronize with the client's respiratory effort, and which mode has the less possible risk for lung injury. And when we're going to see about the modes, okay, so it is going to be broadly under volume controlled ventilation or pressure controlled ventilation. So ventilation modes can either be volume controlled or pressure controlled ventilation. When we say volume controlled ventilation, okay, the volume is constant, okay, but the pressure varies. Okay, so you set the volume, tidal volume in the machine, but the ventilator adjusts the pressure based on the patient's lung compliance, airway resistance, and ensures that the set tidal volume is delivered to the patient. So that is what is volume controlled ventilation. When we say pressure controlled ventilation, here the pressure remains, the set target pressure remains constant, but the volume might vary because depending again, the pressure, what is set is constant. With the set desired pressure, the machine, whatever tidal volume we get might vary. So the pressure is constant in pressure controlled ventilation and the volume varies. Okay, so we are going to see some of the settings, what is possible in volume controlled ventilation. We are going to set the respiratory rate, PEEP, FiO2, flow rate, inspiratory and expiration ratio, inspiratory time, and ETS, okay, and the PRAM. Okay, and PRAM we are not going to have it here. It is we're going to have it in the pressure controlled ventilation. In pressure controlled ventilation, we're going to have set the respiratory rate, PEEP, FiO2, and we're going to set the inspiratory time and the PRAM. So in volume controlled ventilation, we're going to set the tidal volume. Most of the things is going to be same. In pressure controlled ventilation, we're going to set the target pressure what we need to have. Going to the first mode of ventilation, it is controlled mandatory ventilation. Okay, so here when we say, as the term suggests, it is mandatory ventilation. Okay, so there are the mandatory breaths, whatever you're going to set in the machine. The machine is going to deliver those mandatory breaths to the patient, and everything is done by the machine. So you're going to set the respiratory rate, tidal volume, if it is going to be a volume controlled ventilation, and the rest of the parameters, whatever we set on the machine is going to deliver to the patient. So again, in controlled mandatory ventilation, it can be a volume controlled or it can be a pressure controlled. In volume control, it is going to deliver gas at a preset tidal volume. In pressure controlled mandatory ventilation, pressure. So the as nurses, our main role is, because here everything is going to be done by the nurses, all the mandatory breaths are going to be delivered by the machine. So we need to make sure that the patient is receiving sedation and paralyzing, because patients will be very uncomfortable with the settings and there can be patient ventilator dyssynchrony. So always we need to give sedation first and then we give paralytic agents, and also we need to monitor for volutroma. Some of the indications for controlled mandatory ventilation is where the patient is unable to breathe. So patients with apnea, drug overdose, where they're going to have respiratory depression, spinal cord injuries, patients with CNS dysfunction, flail chest, patients with neuromuscular disease, and paralysis from drugs. So these are some of the indications where you would go with controlled mandatory ventilation. And always when patients are on sedation and paralytic agents, we always ensure that we always give an alert that saying that all the invasive lines and as well as the airway, everything has to be ensured that it is double secured, and also we need to make sure that the patient eye care is also taken care, because the patient is completely paralyzed. And going to assist controlled ventilation. So here again is controlled ventilation. So here again you have some mandatory breaths which is set on the machine, but it is assist control. Here the patient is allowed to take spontaneous breaths, but problem here is patient is not able to complete the breath because of respiratory muscles. So what the ventilator does is, when the patient initiates a breath, the ventilator senses the effort and it helps the patient to complete the breath, whether if it is a volume controlled or pressure controlled mode. Based on that, the machine senses the patient's effort and helps the patient to complete the breath. That is what is assist controlled ventilation. But if the patient fails to take any spontaneous breath, the machine will deliver whatever mandatory breaths are set on the machine. So here again, you need to make sure that there can be dyssynchrony between the patient as well as the machines. So you need to monitor for synchrony and also look for hyperventilation, because whatever effort, whenever the patient's initiates an effort, the machine would help to complete that breath. So you need to look for the total respiratory rate and also look for hyperventilation in patients with assist control ventilation. Some of the indications for assist control ventilation, in control mandatory ventilation, we said patients were unable to breathe, but in assist control ventilation, here the patient is able to initiate a breath but unable to complete a breath. So conditions like where patients with myasthenia gravis, Guillain-Barré syndrome, post-cardiac or respiratory arrest, or with pulmonary edema and ERDS, so we can use assist control mode of ventilation where the patient initiates the breath and the machine is able to assist those patient-triggered breaths to the required tidal volume, whichever is set, if it is case of volume control or pressure, whatever the target pressure which is set in case of pressure controlled ventilation. Going to the next mode, it is synchronized intermittent mandatory ventilation. So here what happens, the ventilator provides a preset mechanical breath. Okay, it can be a pressure limited or volume limited mode where specified number of breaths. Okay, so if you set 15 breaths per minute, okay, so the 15 breaths per minute is calculated. So at least it will give in 1 minute every 4 seconds, 1 minute, the machine will be planned to give a breath. Okay, but within that cycle, if the patient initiates an effort to breathe, the machine will synchronize the mandatory breaths with the patient's effort and it will deliver the breath. And if the patient doesn't breathe, then the machine, the mandatory breath, whatever is set on the machine will be delivered to the patient. So here again, the difference between SIME mode and assist control mode. In assist control mode, the patient triggered breaths are assisted by the machine to complete the breath. But in synchronized intermittent mandatory ventilation, here the mandatory breaths are delivered and also it is synchronized with the patient's effort, and the patient is also allowed to take his own breath. But those patient triggered breaths are not assisted by the ventilator. So usually synchronized mode is used as one of the weaning mode of ventilation. So as nurses, we need to check when we check the total respiratory rate. If the total respiratory rate is more than 35 breaths per minute, then we know that the patient is using his patient is taking more of spontaneous breath. And if patient is allowed to take more spontaneous breath, then the patient is going to have increased work of breathing, which can lead to respiratory muscle fatigue. So you need to monitor the respiratory rate, monitor for volutrauma, and also you need to sometimes give sedation to limit if the patient is having to limit the number of spontaneous breaths, and also monitor for hypercapnia. And going to the next mode, it is adaptive support ventilation. Here the ventilator automatically adjusts the settings to maintain 100 ml per minute per kg of minute ventilation, and it is a support. And here it is, as we have seen, it is a computerized mode of ventilation which increases or decreases the ventilatory support based on the patient's need, based on the patient's airway resistance compliance, and it can be used in any patients who requires volume controlled ventilation. So here you need to look for patient, monitor the blood pressure, and also monitor for volutrauma, and also look for any sign of increased intracranial pressure. Next is airway pressure release ventilation. Here the inspiratory and the expiratory levels of pressure, the continuous positive airway pressure are applied for set periods of time and allows spontaneous breathing to occur at both the levels. And this helps to maintain the alveolar recruitment without increasing additional peak inspiratory pressure, which can cause barotrauma. So the nurse's role here is to monitor for hypercapnia. Next is volume assured pressure support ventilation. This again is a variation of a pressure support ventilation with a set tidal volume. So to ensure that the patient receives minimal tidal volume with each pressure support breath. And It is a spontaneous breathing mode usually used in patients to treat respiratory illness, and it is also used to facilitate weaning. So the advantage here is it increases the patient's comfort, decreases the work of breathing and respiratory muscle fatigue, and it also helps in promoting the respiratory muscle conditioning. Next is pressure support ventilation. Here it is the spontaneous, it is used in patients with spontaneous mode, where the patients are able to take spontaneous breaths. So here what we are giving is, we are giving some preset positive pressure which helps in improving the patient's inspiratory effort. So the patient controls the respiratory rate and the inspiratory flow as well as the tidal volume. The machine only delivers a preset positive pressure to help the patient with inspiratory efforts. And it is also used as a weaning mode, and it is well tolerated, better than the SIME mode. And the nurse's role here is to monitor for hypercapnia. Next, another mode is inverse ratio ventilation. Inverse normal inspiratory and expiratory ratio is 1:2. That means inspiration is shorter and the expiration is longer. But when this type of mode is used for patients who are hypoxic, even with the use of PEEP. So we are reversing the inspiratory and expiratory ratio. Instead of 1:2, we reverse it to 2:1. So you prolonging the inspiratory phase. When you prolong the inspiratory phase, you're giving more time for gas exchange, and it also helps to improve the alveolar recruitment and also improve oxygenation for the patient. And also shorter expiratory time prevents the alveoli from collapsing. So the modes whichever is not closer to normal way of breathing, we need to make sure that we give adequate sedation and paralyzing. Okay, so here in inverse ratio ventilation, patient would require sedation and paralytic agents. Going to the complications, I've discussed complications of mechanical ventilations are more. I'm not going into the details of all the complications. I'm specifying only the complications related to the ventilator settings and the modes. So the first one is ventilator-induced lung injury. So when we say ventilator-induced lung injury, it is patients can have damage to the lung because of the varying pressures, volume, what we have. So barotrauma is the patients having damage to the alveolar wall because of high lung inflation pressures. That is what is seen in barotrauma. In volutrauma, it is caused because of alveolar over-distension. So this causes damage to the alveoli, and atelectaoma is caused because of the shearing forces. Every time you repeatedly open and close the collapsed alveoli, the shearing forces causes damage to the alveoli, which can cause air leak. So there can be, whenever there is barotrauma, volutrauma, atelectaoma, there is excessive alveolar wall stress, which leads to damage to the alveolar capillary membrane, and it leads to air leak in the surrounding places. And also, all of this can also lead to release of cellular mediators and also release of initiation of immune response, which is called as biotrauma. So barotrauma, volutrauma, atelectaoma, and biotrauma, all of this leads to lung injury. So how do you prevent barotrauma is to ensure that your patients have low tidal volume, and also we need to look into the pressures what we set, and also to make sure that we keep enough PEEP to prevent the alveoli from collapsing, to prevent atelectasis. And the next complication because of ventilator settings is patients can have bucking with the ventilator, or we call it as patient-ventilator dysynchrony or fighting with the ventilator. So the factors which contributes to this problem is patients can have anxiety. Anxiety can lead to patient-ventilator dysynchrony, hypoxia, and increased secretions, patients hypercapnia, inadequate minute volume, and pulmonary edema. So we need to identify what is the underlying problem and need to correct those problems before you paralyze the patient. Because if you sedate and paralyze the patient without treating the underlying problem, the underlying problem will be masked. So prevention, you need to make sure that patients with modes, as I told you, whichever is normal, patient there we need to give adequate sedation and paralyzing agent. If patients are having pain, we need to assess and ensure that we give analgesics to the patients. And also, if patient is having anxiety, fear, we need to make sure that adequate sedation is given for the patient. So the main purpose is to increase patient-machine synchrony. So to conclude, mechanical ventilation is an integral part of intensive care. So it is very essential to have an understanding of the modes, pathophysiology, as well as lung mechanics of various respiratory disorders, and continuous monitoring of the vital parameters is mandatory to prevent complications and to improve patient outcomes. Any questions?
Thank you so much, ma'am. Excellent discussion, and ma'am discussed modes, factors to be considered, general modes, SAMV, ARPV, clinical applications, complications, and nurses' role. I can assure you that our attendees have learned enough from your presentation about ventilators, various modes, complications, prevention, and the nurses' role. Thank you so much, ma'am, for sharing your wisdom with us. Thanks a lot. So let us move on to today's third speaker, Ms. Ashwati Ji, HIC Nurse Manager, Angels Global Health City, Chennai. She has a total 10 years of experience in clinics from cardiothoracic recovery ICU and in nursing administration. Being an infection control nurse from past 5 years, published an article in International Journal of Scientific Study on oral cancer in the year of 2018, and she is a member of TNA, participated in multiple webinars, being a resource personnel, panelist, and organizer committee, was an organizer for an International Nursing Symposium, IHH Healthcare Berhad in the year of 2021, tremendously prepared the organizations for numerous accreditation programs like NABH, 5th edition NABL and NABH Nursing Excellence, Cargo, AC accreditation for CSST, and Infuse QAP by INS. Winner at the Tamil Nadu State Level Annie Elocution Competition 2023 in staff category on topic contribution of Indian nurses to the future of Indian healthcare. I'm welcoming you, ma'am, to discuss about infection prevention practices in ICU. Over to you.
Thank you, ma'am. Good afternoon, all. Thank you so much for the wonderful opportunity. It's my pleasure to be part of this webinar, first of all, organized by Annie, collaborating with the Critical Care Nurses Society. My slides are visible, ma'am?
Yes, ma'am.
Thank you. So we'll see about the infection prevention practices in ICUs. So the objectives for today's learning is importance of infection control practices, vulnerability of ICU patients and phenotypes of HAI in ICUs, surveillance and its vulnerability, modalities of infection prevention controls and ICU designing and planning, and antiviral stewardship, local antibiogram, employee vaccination, outbreak investigation, and our best practices learning outcomes. So why it is important to have an infection control in intensive care units? So higher incidence of hospital acquired infections happens in intensive care always. And again, it will be leading to the increased morbidity and mortality. And also again leads to the increased healthcare expenses for the patient as well. This is again a reason for the increased incidence of multi-drug resistance and other resistivity organisms or bugs in the ICUs. And also it is act as a catalyst for the quality control in other areas of hospital, because if any outbreak or the infection happens in the intensive cares, it will be directly having an impact on the other areas of the hospital as well, and quality of the patients, visitors, employees, and the environmental safety.
Ashwati, sorry to stop you. Can you please switch on your video? We are not able to see you. Yeah. Thank you.
Thank you. So, cost of the 5 most common hospital-acquired infections is a study done in the US. It shows like the highest number of the incidence of HAI happens in surgical site infections, followed by ventilator-associated pneumonia and C. diff in US, and the third one is the central line associated bloodstream infections. Ma'am,
Try going back and then come forward. Share once again, Ashwati.
yeah. Is it visible now, ma'am? Yeah. So vulnerability of ICU patients, what comes on the points like presence of underlying comorbidities, already they will be having the multiple comorbidities, and intensity of their acute illness, presence of indwelling devices. There's some patients will be with multiple indwelling devices, and frequent manipulations and the contact with the healthcare workers, early suctioning or some other procedures, sample collection, frequent sample collection. These are all will make an increased contact with the healthcare workers, and prior hospital stay and antibiotic exposure, recent antibiotic treatment, getting admitting to the ICUs also will be making an reason for making the vulnerability of the ICU patients to develop any kind of infections. Ma'am, can you share from your side, if you don't mind? I have some troubleshoot here.
Stop share, Ashwati, we will share.
Slide number 5. Slide number 5. Next. Okay. So the reason for the transmission of infections in ICU, that is, one is the poor infection control practices in the intensive cares, and environmental contaminations and equipment contamination, again chemical failures and staff education. Coming back to this poor infection control practices in the sense of from the hand hygiene, it will make an reason for or the risk of the transmission of the infection will be always low. And environmental contamination, for example, an infected C. diff patient is getting admitted, and followed by the post-discharge, the environmental cleaning is not happening properly. Again, it will be a reason for the infection to the next patient. And equipment cleaning is again a reason. And chemical failure, this is the area where sometimes our team will be failed to focus on this, because like, for example, hypochlorite solution, there will be coming multiple forms of solutions are available currently. Some comes in the form of tablets, some will be in the form of powders. So then we will have to make sure the consistency and the composition of the material gives the proper action which we are supposed to have it, so that it will be always success in the process of cleaning as well. And the staff education from the beginning of induction itself, it is mandatory to give it. Next one. So the 5 sequential steps for the cross-contaminations, like shedding of organism from the patient to surrounding. This is the reason where we always remind about the moments of hand hygiene after touching the patient's surroundings, and the transfer when it will be transferring to the hands of healthcare worker. And organism must be capable of surviving in the hands of the healthcare workers. If suppose the staff is not doing a hand hygiene properly, then appropriate hand hygiene, again, it will be making a cross contamination with the other patient through the healthcare workers. So these all surrounded areas, these circled areas, we can see all high-touch areas will be a highest sources of different kind of pathogens in intensive care areas. Next slide, please. So there is a study shows like infection control and hospital epidemiology. Some morbidities are risk factors we can modify it. Some are not at all modifiable. Some like age, sex, and economical status, and the hospital or the ICU type of hospitals we cannot. But length of stay we can adjust, like early shifting of the patient from the ICU to the ward, where the nurse can be an advocate to inform the consultant regarding the patient health improvement. The patient can move to the ward, so we can reduce the length of stay in the ICUs. And device utilization rate, multiple devices will be present for a patient. We have to evaluate, the nurse has to evaluate whether all the lanes are necessary to keep it there, whether the patient is going on with the IV injection or not, or if is it really required to keep an arterial line. So all the details we'll have to analyze every day, and we have to reduce the number of device utilizations. And HAI rates, obviously, as through multiple approaches like bundles, we'll have to reduce the HAI, and definitely we can control it. And cleaning and disinfection of the equipments also, we can have a concentration so that the infection risk can be prevented in ICUs. Next slide, please. So phenotypes of HAI in ICUs, coming to the class C, we can say like intraluminal migrations from the tip. So in this, we can prevent the simple method of cleaning the hub with an alcohol swab. 70% alcohol swab can be used before accessing to any of these ports, so that entry of the pathogen through the intraluminal migration will be prevented. And also like extraluminal migration, here the skin touch, the portion can be applied with a sterile dressing so that it will be protected, so other pathogens will not be entering inside to the patient body. And the next third risk for the class C is like introducing the microorganism on the catheter tip during the insertion time. Either it can be during the insertion time, or if it is we are not providing the man sterile, or there is some pathogen or some infection is there on the injection or the IV fluid which we are introducing through the line. That is also the other reason for developing the CLABSI to the patient. And again, coming to the CORT, it is an extraluminal where the early at insertion time, all the sterile precautions will be followed. If the team is not following the proper sterile technique while inserting the catheter, Foley's catheter, that can be one reason for introducing the infection to the patient. And manipulation should be prevented, and late by capillary action is the other reason. And ascending perineal bacteria, that can be prevented by the giving a proper care and fixations. And in intraluminal, breaking the closed drainage systems and contamination of the collection bag urine is the other reason. And urine stats in the bladder or the bag also can be one reason, which is not, we can prevent it. Next slide. So coming to this VAP, the common sources for the VAP pathogens, like one can be the aspiration reason or the intubation procedure if they are not using the proper sterile protocols. So that will be one reason for introducing the infection, or the biofilm formation, which contaminated secretion can be developed which you are not suctioning it properly, or if it is getting aspirated, then it can develop to an VAP later. Next slide. So this is the infection control practices in ICUs where the hand hygiene steps has to be sorry for the interruption, ma'am. So this is the steps of infection control practices where we have to be focused on the ICUs. Next slide, ma'am. Next slide, ma'am. So what are the measures to improve the adherence of the infection control practices in ICUs? That like employee education in hand hygiene is very, very mandatory, including the standard precautions, and ready to access the PPAs. If the availability is not there on the spot, there can be a breach of use of PPAs. So that should not happen. And audio reminder in public announcement system in the hospitals. For example, every 4th hourly, we are giving an announcement in the hospital through a public announcement system stating this is the time for you to do the hand hygiene, so that all the employees will be aware indirectly, apart from their busy working on the patient care area. So they will be try to adapt whenever they're giving an announcement. Same like posters visibly can give a reminder to them so that we can improve the hand hygiene complaints in the ICU team. And video based learning, rather than teaching them in the when we'll get an new joiners, instead of sitting them only with the posters, let's play with some videos in using with some colors in the gloves, how it is actually effective when you do all the 6 steps of hand hygiene, or where it will be lacking when you are missing one step. So this will be making them something interesting from the first day of the joining to the organization. Will be giving a special trainings, and simulation based training also will be really effective when we teach them from the day of joining. And clinical audits, obviously, to check the practical complaints of the ICUs, and possible disciplinary actions if there is a repeated lapse in adherence by concerned employees, that we can take some small disciplinary actions or giving them an extra teaching so that it will be prevented in futures. Next slide, ma'am. So this is types of isolation. Everybody knows, like based on the route of transmission, we will be isolating them to droplet, airborne, and the contact isolations will be kept. Next slide, ma'am. So coming to the isolation rooms, for a standard negative pressure isolation room, the pressure difference should be greater than 2.5 Pascal, 2.5 to 8 Pascal always. For example, it is a negative pressure room, it should be minus 2.5 Pascal minimum. If it's a positive pressure room, it should be positive 2.5 Pascal pressure difference should be there. And along with this, the air existing in negative pressure environment has to be filled with a high efficiency particulate air filter and through a certified leakage free system to completely remove the virus and bacteria. Like this HEPA filter should be there if we are setting for a negative pressure, or we are planning to place some infected patient in the ICU. This is mandatory, and this the efficiency of the HEPA filter should be checked every 6 months, and validation also should be done. And the changing of the HEPA filter can be done once in 2 years, once in 2 years, or once in year based on the organization policies. Next one. So the bundle approach, this is a collection of evidence-based interventions to prevent infections in the ICUs. The simple principle is all or none. If we are following, then it should be for all the interventions, and it is for all the patients, and it is for all the time, so that it will be really effective to have a control on the HAIs. Next slide. So VAP prevention bundles, the quality of evidence for this VAP prevention bundles is high. It is showing in the forms like hand hygiene is the one thing where we can prevent really with the VAP, and use of NIV in appropriate scenario, and sedation interruptions, and assess readiness for the extubation. Here again, the nurse can advocate to the doctor after keeping a sedation interval. We can see, and we can request, or we can communicate with the consultant whether if the patient is ready to extubate, can we start the weaning or not, so that the long days in the ICUs will be, long days in the ventilator will be stopped, and we can extubate the patient early. And circuit change only if it is visibly soiled. There was an old practice in ICUs. Every limited period of time, the circuit has to change. So that is again we are introducing the infection. So now it is like a circuit change only if it is visibly soiled. That really works. And moderate quality of evidence for VAP prevention bundle is use of subgluteal suction ports and cuff pressure monitoring and head end elevation. Here for this head end elevation, we say it's like 35 to 45 degree, but if it is 10 degree, there is a research study shows even if it is a 10 degree head elevation for a ventilator patient, still it is preventing a certain amount of VAP risk. So that is one other important point which we have to focus. And other is like oral care with chlorhexidine and closed inline endotracheal suctioning. These and all again contributing for the prevention of VAP. Next point. So coming to the SCORT prevention strategies, again, obviously the insertion of the catheter should be properly done with all the sterile techniques, and leave the catheters in place only as long as needed. Insert the catheter using aseptic techniques, and the sterile equipments should be there. And following aseptic insertion, maintain the closed drainage system. There was an old practice where we sometimes, even in ICUs, due to a decreased urine sample or some other reason, we disconnect it and collect the samples, and so that will make an that is a reason for entering the pathogen inside that urinary tract, and it is a reason for developing the COT. So that should be avoided, and maintain unobstructed urine flow, or again backflow from the bag to the bladder. That is again the other reason where we actually neglect, but that is a reason or contributing factor for developing a COT. And again, obviously, hand hygiene is the reason where somewhere we can prevent the COT in the future. Next slide. So now, this is the point which is like ICU designing and planning. What we have to plan such a way to prevent the infection. The engineering control has a 50% role, and the remaining part is like human being practical, or the employee or ICU team practice. But the remaining 50% is like how the engineering works happens for an ICU designing. So the total bed strength recommended between 8 to 12. Can not less than 6 or not more than 14 in any cases. And space per ICU bed recommends that is from 125 to 150 square foot areas. That is almost like 12.5 square meter. That is 3 into 4 meters. That should be the ideal distance between the each bed. And 2 beds should be specially designated for any infected case, or where we have to do for an hemodialysis. The RO port and the required setup should be available in the ICUs. And 10% of the ICU beds, that is like 1 or 2 out of this 12 beds, where we can use specifically for the isolation areas, where we can keep all the burns or any other highly infected patients can be isolated, these special isolation rooms. And ICU should be fully air conditioned, which allows control of temperature, humidity, and air change. Here it is, the temperature should be 22 to 26 degrees Celsius, and the humidity is like 20 to 60%, but ideally we say like it is a 55% of humidity should be maintained in the ICU. And air exchange, it is 12 air exchange per hour. It is a minimum air exchange which is recommended for the intensive care areas or the isolation rooms. So it should be there. And if at all it is not possible to maintain the air conditions, then it should we can have an open window system at least, so that natural air exchange will happen, so that the atmospheric infection rate will be little controlled. Next slide, ma'am. So continue to this negative pressure isolation room. That is, again, we said if it is having with an HEPA filter facility, then the filtration capacity will be less than 5 micro also. So if it is a negative pressure room, the pressure difference should be minus 2.5 Pascal along with the HEPA filter facility. And if it is a positive pressure room, where we can isolate all the neutropenic or bone marrow transplant patients or other transplant patients, we can keep there. So there again, it will be plus 2.5 Pascal difference than the normal atmosphere pressure. And HEPA filter, obviously, we as discussed earlier. Next slide. So this is the minimum air exchange per hour for various healthcare settings. So coming to the last point, it is like bronchoscopy procedure room or any other critical procedure room or isolation room or any intensive care unit. It is recommended minimum 12 air exchange per hour. Other areas of hospitals like ward, OPDs or the reception registration areas, where other areas can be, it can be minimum of 6 air exchange per hour. Next slide. Next slide. Yeah. So coming to this antibiotic stewardship, coming to the ICU, it is important. We should definitely have an antibiotic stewardship program should be running in our hospital, which will be like major principle, like promoting interdisciplinary strategies, improving infection prevention control practices to have a control in the prescription of the higher end antibiotics. Any higher end antibiotic prescription should be tracked, and we should be cross-verified by the core committee, so that unnecessary or if it is not required, the higher antibiotic should not be prescribed from the beginning. So that is one thing. And also, like, the sensitivity of the culture report is it mandatory? If the organism is already sensitive to the basic antibiotic, we can start from that, or we can de-escalate based on the culture report. And also, it is like switching to the IV antibiotics to the oral is can be suggested, or the nurse can advocately talk to the consultant to switch off the antibiotic from IV to oral if it is possible. So that reduction of the or reduced controlled usage of antibiotics also can be done. Next to here, we are projecting our hospital antibiogram, which is developed on January of 2023 based on the data of 2022 data, Jan 2022 till December 2022. So here it is like equally is written like sensitivity of 92% to amikacin, and again if come down, it is Klebsiella shows like only 63% of sensitivity for amikacin. So it is mandatory to have and look on the local antibiogram, so that we should not develop more or we are not contributing much to the development of a new multi-drug organism in the organizations. Next slide, ma'am. So this is again the continuation of the antibiogram, but what we have discussed before. So here it is Pseudomonas aeruginosa. It's showing like the minimal sensitivity is ciprofloxacin, which is showing 72% only. So the highest sensitivity is only showing to the cholesterol. Same like Sustainobacter baumannii complex. Here it is amikacin is only 70% sensitivity, and ceftriaxone is only 80%. Here again, cholesterol is only showing for 100% of sensitivity. So that this analysis will give us an idea like what kind of resistivity is developing in our organization. Based on that, we can make people aware, or we can make the ICU team aware about this resistivity changes which is happening in our organization, so that we can work together for this. Thank you. Next slide, ma'am. Next slide, ma'am. So next is again employee vaccination. For the ICU employees, will have to give for certain vaccinations. Hepatitis B vaccination is mandatory for everybody who is working on the patient side, including the ICUs. And flu vaccine is again mandatory for giving to the ICU employees. Can be given once in a year, the beginning of the flu season on your our organization or our city. And tetanus vaccine is mandatory for the housekeeping, and typhoid vaccine for F&B staff, those who are supplying the food to the ICU patients. We should be definitely should be vaccinated for typhoid vaccination. And hepatitis B-A vaccination again for the F&B team. Beyond this, some based on the organization policies, chickenpox vaccine also can be given for the ICU employees. Next one. Next slide. So next is outbreak investigation. Something is outbreaking in the ICUs. How we have to investigate on this. For example, there is a chickenpox, there is a new infection is reported from a medical ICU. So we have to see what infection it is, and we have to see what type of infection, how it is spreading into it, and determine the causes. What is the reason for the first case, whether it is from the hospital inside itself or somebody from the outside hospital through the form of employees traveling from the home to the hospital every day, or through the visitors, or the newly admitted patient, or the other healthcare workers brought the infection. We'll have to evaluate where is the first source of infection developed from. Based on that, we'll have to plan to prevent spread of the new cases, or to prevent reporting the new cases from the same areas. So that is for the control part comes. So this is the other area where we have to focus in the ICUs to have an infection control. Next slide, ma'am. So this is certain best practices where we can do in our units, like certain liver law kind of Venflons, or rather than going for an sterile gloves all the time, we are getting an alternative sterile petal gloves available for other for any frequent procedures, sterile procedures like suctioning can be utilized for this, and syringe with coming with an cork, eclipse needle it is called. So this and all can be preventing the infection to the patient, to the employee as well, and portable puncture proof containers so that the disposal of the needle can be done immediately rather going to the patient side or where the available PPC puncture proof container is there. And other advanced product can be used in the ICUs alone to prevent the infection rates. Next slide. So the learning outcomes for today's session is the pressure difference in the isolation room should be greater than 2.5 Pascal to 8 Pascal. And the bundle approach is the collection of evidence-based interventions which we have to do. All the point has to be done for all the patient for all the time. And airborne precaution rooms or the isolation rooms, minimum air exchange per hour is 12 air exchange. And outbreak analysis steps comes like confirm, describe, determine the cause, and to the controlling of the newly diagnosed infection. And the air exiting in a negative pressure environment has to be filled with the HEPA filter and through a certain leakage-free system to completely remove virus and bacteria. It is mandatory. And space per ICU bed recommended is 125 to 150 square feet areas per bed. Thank you.
There is a question on the chat box.
Yeah.
Any of you could answer the speakers, Madam Mary or Ashwati Madam, you could answer the question.
Yes. I'm just going through the questions.
How about handling the central line lumens? If it is lying on the patient, would it cause infection?
Patient chest.
Harbor infection while it's lying on the chest, especially multiple lumens like 3, 5, 7. How do we handle it?
It can be, if lying on the patient chest, can be covered with a sterile gauze or the Gamgee pad. So every day, based on the, when you do the routine care in the morning, we can access it, we can open it, and we can close it in a sterile way. So whenever you access to the central line, you will be with an sterile gloves, and you will be having an assistant to open the alcohol swabs or the injection or posiflush, whatever it is. So with the sterile gloves, we can open the covered Gamgee pad, which is covered on the 3 lumens, which is lying close to the patient chest. Give the injections and we can reclose it and place it. So that is one thing which we can do it. And next question is, how do you collect the urine culture from the Foley's catheter? Culture, it is one way is like all the sterile procedure should be sterile precautions is mandatory, like wearing all the sterile PPE, sterile gloves, doing a proper hand wash, and coming with an wearing a sterile gloves, and you will be having an assistant patient, you will be having an assistant to do the procedures. And we can clean, if it is a lumen one, we can clean it with a betadine. We can clean, we can wipe out with a normal saline, with an aspiration technique, with a new syringe, we can aspirate it and take in required samples. Any other questions, ma'am?
There are other questions.
There is a suggestion also.
How can the personage?
Wait. There is a suggestion that they are using a sterile towel to cover. That's also okay.
Sorry, ma'am.
There is a suggestion that has come here that what they are doing as a practice, we use sterile towel to cover CVC multiple lumen in our ICU.
Ma'am, sterile cover, the possible reason what we have stopped was it will be little weight. Even if it is a cut piece, it will be hanging.
Yeah, exactly. That is what I want you to highlight.
And that is one thing. And second thing
Not
is
add weight to the lumens.
And second reason is if the sterility is not happening properly, or if it has undergone a proper sterilization from the CSST and we are receiving it, since the material is big, we have to handle it properly without touching anywhere, and we have to close it and keep it very carefully. Otherwise, again, it will become unsterile.
There are questions on environmental surveillance what are the environmental surveillance which they have to do in ICU, as well as guidance on fumigation? Is it recommended or not?
Fumigation is not recommended by any of the guidelines, ma'am, since few organizations still they follow based on the old practices they were doing from years back. And environmental surveillances that we can do for ICU is again based on your organization policy, because that involves cost and money, and also it should get approved through the committees. So our organization policy is every ICU should have an ICU surveillance once in a 6 months if the census permits, or if there is a major construction happens or any renovation activities happens, we close the unit or we interchange the unit. Especially when the COVID happens, we were interchanging all the ICUs. So once the infected patient is over a discharge and they are moving back with the other ICU team, again we'll be doing a culture, or we'll be taking the surveillances. And after any major constructions, renovation activities inside the ICUs, or if they are opening the roof and they're checking some major cabling activities or AC sealing activities, then again we'll have to clean it thoroughly and we'll have to take a cultures again from the ICUs. And one more question is from Shiny. How many has the percentage been calculated in the antibiogram? Can this be explained in a antibiogram is a teamwork with the HIC team and clinical pharmacologist and microbiologist, HIC chairperson, all other team. It's a teamwork. Like we will be sitting and analyzing for the last 1 year data. From this January, we were analyzing for the last year, January 2022. Till December 2022. So we'll be evaluating all the culture reports which we released from our organization. That is for the IP and OP patients. Then we will be seeing it. What was the sensitivity? How many sensitivity we gave for this particular organism. So that will take little time, but end of the teamwork. By 1 month or 2 months, we will be coming to a conclusion. This is the sensitivity pattern or the resistivity rate of this particular organism in our organization, or whether it is deviating or it is worsening from the last year. Like for example, Klebsiella, as we discussed, whether it was 37% sensitive for amikacin, whether it was last year also, 2021 also, amikacin was sensitive for 37% for Klebsiella pneumonia. That we will be evaluating. Whether the sensitivity is reducing, that shows the resistivity is increasing in our organization for Klebsiella. So it will be like that. So the end of the year, we will be getting the report on this antibiogram.
Due to lack of time, I request Madam Ashwati if you could answer the questions on the chat by typing out your answers. It will be helpful because we
sure, ma'am. We will. Sure.
Over
Thank
to
you, ma'am.
Dhanalakshmi.
Thank you, ma'am. Infection prevention and control is safe healthcare for everyone all the times. Yes, she has discussed importance of infection control, reason of transmission, 5 sequential steps for cross-contamination, phenotypes of HA in ICU, practices, tips for practice, types of isolation, bundle approaches, VAP, prevention, ICU designing and planning, antibiotic stewardship and local antibiogram, and employee vaccination, outbreak investigation. Especially she discussed with evidence-based practice. I believe your presentation made the attendees aware of the in-depth information and the importance of infection control practices in the ICU. Thank you so much. So let us move on to last speaker, Mr. Mario Colambal. He is a nurse educator, Fortis Hospital, Mulland. He is a MSc nursing in medical surgical nursing, especially in oncology subject. 9 years of teaching experience in nursing. His career ladder started from staff nurse, clinical instructor, moved to CAP custodian, center observer and paper assessor for MUHS examination. His remarkable achievements are that he conducted Sankalp, an initiative under Ministry of Women and Child Development and Maharashtra State Skill Development Society with the eye. He transformed India to rehabilitate underprivileged women of society. She headed Parivartan under Ministry of Women and Child Development and Maharashtra State Skill Development of Society with eye transform India to rehabilitate jail inmates of Nagpur and Yerwadi jail. And he has currently working as a nurse educator at Fortis Hospital, Mulland, and he has attended numerous staff development program and conferences. Sir is here to discuss about communicating with the ICU patients and their attendants. Welcome you, sir. Over to you to discuss about the topic.
Thank you so much, ma'am. Thank you. Yes, so is my screen visible to everyone?
Yeah, Mario.
Yes, okay. So thank you for giving me this opportunity to take this session. And after all the hardcore topics that we had, the heavyweight topics that we had, we are coming to a light session, something like communication, but a very important point because this acts like the glue to keep all the skills and everything together. So my topic for today is ICU communication. So according to me, nursing has had a major shift from the time of Florence Nightingale. Initially, it was more about compassion, care. And as the years passed, as decades passed, we are more skillful and more knowledgeable, and there's so much added on to nursing. I feel somewhere the balance is kind of, switch more towards the skill, and compassion somewhere is taken a backseat a little bit. So we have to get that back, and that can be done best through the help of communication. So after today's session, the learners what they can do is they can learn to communicate with patients in ICU. They can definitely improve their skills in communicating with patient family. They can use enhanced communication to improve effective communication and adapt special communication strategies to handle adverse events. So what is communication? There are many definitions for communications out there, but I feel this is one of the best because it says communication is an exchange of facts, ideas, opinions, or emotions between two or more persons. Okay, so even when we communicate with the patients, it's not just about the facts and the ideas, but definitely also with the emotions that we communicate between them, and it creates the connect with the patients and us. So what are the communication challenges that we face in the ICU? We've divided into two, patient aspect and family aspect. So patient aspects, the challenges we face is communicating with intubated patients, sedated patients, okay, especially those who are weaning out of sedation, and handling adverse events. And in family, we have timely updates on conditions, which we need to keep doing, okay, regularly. Then counseling for complicated interventions, handling adverse events, breaking bad news, handling aggressive members, and of course, unfortunately, and even in the event of death. So let's see one of them. Okay, so communication with patients. So definitely, as I said, we need to communicate with patients a lot. Okay, nurses nowadays, they say they are overburdened with documentations and work. Okay, but we need to keep that compassion and care aspect. Okay, that is the basis of our nursing. So we need to maintain that. Okay, and by doing that, we can achieve that by communicating with our patients. So how can we communicate with our patients? Obviously by staff rounds. Okay, so staff rounds are very important, especially in the ICUs and even in the wards. Okay, where in the wards, especially where we have 1:6 patient ratio, and even the ICUs where we have 1:2 patient ratios, staff roundings are very important. Okay, it can be 2 hours or hourly roundings depending on the patient's condition. Next better thing we can do is verbal communication. Again, to the patients who can speak in the ICUs, definitely verbal communication is the best form of communication that we can use. Taking it a step further, for patients who cannot speak, okay, or those who are intubated patients, we can definitely use non-verbal communication gestures. Okay, simple gestures we can use like, are you okay? Not okay. Okay, so if they require suctioning, we can give them a few gestures, maybe eye blinking twice for suctioning, or they can use some hand gestures that we can, previously tell them to use. So that can be done. Apart from this, taking it a step further, we have use of display charts. So the next slide, I have a display chart to show you. So many hospitals nowadays, they come up with display charts where it makes it very easy. There are many pictures over there, and the patient can just point out and tell you what he requires and what he needs, basically. Written messages, if patients can write, you can provide them with a pen and a paper. Okay, and nowadays we even have these electronic writing pads wherein you can we get them for hardly 100 rupees, wherein you can write messages on those pads and you press a button and the entire slate gets clean. So we can have these slates for these patients where they can write messages and that can be used rather than using the pen and the paper. Use of video call. Okay, so even during COVID times, video call was used very extensively, and it helped communicate with the patient, between the patients and the healthcare team members. Last point, but very important point, please do not miss on this point, is involving family. We as healthcare team members, nurses, have to involve family whenever we are discussing or communicating with our patients. We have to use family as a third wheel, as the additional player, in order to get our work done and in order to have a smooth transition in providing care for our patients. Okay, so just a personal example, if I tell you, when I was back in 2008, I had cerebralitis and I was quadriplegic and I could not speak. I had very incoherent words that used to come out of my mouth, which nobody understood, and everybody found it difficult to understand what I was saying. But my mother, okay, very surprisingly, she kind of understood whatever I was saying. So whenever she was not around, I used to get very flustered because whatever I wanted or needed, she was the best person to understand. So please, people, do not, nurses, do not underestimate the power of involving family in patient care. Okay, this can be your actual strength in creating a bond with the patient and also helping them recover fast. So as I said, this is the communication chart. As you can see, there are many pictures over here. We have a set of alphabets and numbers too. So whatever the patient wants, okay, if they're capable, they can also point out to the picture and ask for whatever they need. Now you all may be thinking, what about the patients, like, as I said, I was quadriplegic. What are those patients who cannot move their hands and who cannot write or cannot point out to something? Well, that's what we are looking forward to. And this is where we use augmented reality or artificial intelligence. So nowadays, when we go to the restaurants, okay, it's very common. The number of waiters have reduced, if you've observed. All we need to do is go to a particular table, scan a code, over there the menu comes up, and we can choose whatever we want to order. And obviously this gets captured onto the billing area, and at the end we even get a bill coming up. Okay, so same way we can use this technology even into the medical field. So one of them is Small Talk Intensive Care. This is one of those apps that are present currently in the Apple Store. So you can use an iPad or an iPhone. I just took a screenshot of what it actually is. So just one of those things, one of the screenshots shows, okay, for example, I have chest pain or I have shortness of breath. So all the patient needs to do is just click on one of those, and this captures onto the central monitor, and then immediately the patient, the nurse can, or the healthcare team members can come and attend to the patient, just exactly like the example that I gave you about the restaurant. Apart from this, again, if the patients, what about delirious patients or patients who cannot move? So for that, we are coming up with something which since 2016, they've almost done with it. So something called as eye control from Tel Aviv in Israel. One of the companies over there have created this technique, okay, or this basically technology, wherein, as you can see in this picture, there is a small device on the patient's head, okay, and this is a screenless technique. So the patient basically doesn't have to look or is not exposed to any screen as such. There is a small monitor in front of the patient's eyes. So based on the patient's eyes movement, okay, there are predisposed criteria already entered into the software, wherein the monitor captures what the patient needs, and that can be relayed onto the central monitor or into a audio form to the healthcare team members. Okay, so this can be the patients can communicate with the healthcare team members just with the help of eye control or eye gestures. So this is one of the advancements, and I'm pretty sure that this will catch on to most of the ICUs around the world. Coming to the next section, that is communication with family. Okay, so communication with family is another very tedious task, okay, for healthcare team members. So the best thing to do is to involve, at the time of admission, is to involve only two next of kin to be communicated. So what are things we need to communicate with the family? It's better that we communicate with only two people, so that there is a continuous flow of information to the family and to the patients. Use of translators if necessary. So if the family members need translators, according to NABH standards, each hospital needs to have a set of Indian language translators and international translators. So this can be in the database, and if needed, whenever needed, the number can be taken from the database. Translators can be used to communicate anything with the family or the patients. Now, what do we do in family communication is, what do we communicate? Timely updates on patient's condition. Okay, so again, this is another challenge for the ICU nurses, is to make sure that during the visitation hours, okay, the nurses can communicate whatever needs to, okay, to the family members. regularly. Apart from that, what else they can communicate is the proposed care of treatment. When we discuss about the proposed care, for example, even if patient is shifting from one department to another department, for example, if the patient is going on a step up from a ward, if the patient is going to the ICU, obviously, to give you an example, whenever we are sitting in a flight and we've booked an economy class seat, and all of a sudden the pilot or the cabin crew comes and tells us, "Ki, sir, you are upgraded to a business class or first class." The first thing that pops up to our mind is obviously, do I have to pay extra money for the business class or first class? So same way, whenever you discuss proposed care, the next immediate thing that should pop up into your mind is estimate cost of treatment. So again, the estimate cost of treatment also should be discussed with the families whenever you're discussing about the proposed care, and let them take the decision, okay, and involve them in the care of plan. Informed consents is another thing that the nurses also can discuss with the family members. Okay, so you're supposed to make sure that the consents obviously are taken by the primary consultants, but the nurses to make sure that they do explain things at their level so that they can ease out the communication between the healthcare team members and the family. The last is expected outcomes and complications. So nurses have to be knowledgeable about all the expected outcomes of the treatment modules and the complications that can arise from whatever treatment they're going to go ahead with. And this again has to be communicated with the family. So this is just an example of the forms that we use over here. So what, as the previous slide, whatever we communicate with the patient's family or the patients, we can use something called as a patient family communication form. Okay, so this again is a very important form. Again, to all the young nurses out there, I'd like to tell you, anyone who tells you that documentation is a burden and it is eating your time, let me tell you that documentation is very important. Maybe 20, 30 years before it wasn't, but considering how the world is today, documentation is very important for healthcare team members and for nurses in order to safeguard us and also to make our work very, very smooth. So anytime you want to discuss anything with the family or the patients, all you need to do is enter the date, enter the whatever discussion has been done with the family. In short, hardly 2 minutes it takes. You sign and please take the family members' signatures. I've seen examples wherein based on the Braden score, the family was advised that alphabet be provided for the patient. But then when it came to the cost estimates, the family refused. Ultimately, the patient developed pressure injuries. And that time when it was discussed, the family members very bluntly denied that they were offered any alphabet. So this is how, as I said, to safeguard the nurses and the healthcare team members, it is always best to use these forms of communication, and very important is to document it. Coming to our next important topic, enhanced communication. Okay, so what is enhanced communication? I can to tell you in very short before you read what is on the slide over here. I'm pretty sure all of us have done this in our life. So just to give you an example, since we've all finished nursing and we are all working now, so I can use this example. I don't think anyone would get offended or hurt. So just imagine or think that you've got a gold medal or a distinction in your third year BSc nursing or in your third year GNM nursing. Okay, you've got a distinction or a gold medal in med-surg. How do you go and tell this to your parents? Obviously, you're excited. Okay, you're not bothered whether your mom is cooking or your dad is working on something or they're busy. You just run up to them and you kind of announce to them that mom, dad have come first in third year nursing in my class. So you're very excited and you just give out the information. But let's reverse this example now. And let's say, for example, I hope I'm not hurting anyone's sentiments. Okay, just an example. But just think back and think that now, what if we failed in third year BSc nursing, or if we fail in one of those subjects, or even in maths? Okay, I'm pretty sure most of us may have failed in some of the small tests during our tuitions in school times. Now, how do we provide this information to our parents? Are we as excited? Obviously not. We obviously look at the situation. Okay, if mommy is cooking in the kitchen, that's a big no-no. Please do not provide this information that we failed in maths. I'm pretty sure we may get some utensils flying towards us. Okay, so we look at the situation, maybe post dinner when everybody is relaxed, mommy, daddy is relaxed, all the cooking is done, all the housework is done. You ask them to, sit down, mommy, daddy, please sit down. Maybe you put the TV off so that you do not want any distractions. And then very slowly you gauge how their mood is. And based on that, you break the news. I have something to tell you. Don't worry, nothing serious. but we had a small test in maths in school and we failed in that. Okay, so this is how we break the message. This is exactly what enhanced communication is. I'm pretty sure we've all used this in our lives, but we didn't know that it's called enhanced communication. So enhanced communication is using the methods of communication basically to ensure meaning and understanding through the recognition of others' limitations. So definitely the patient's relatives, the patients and their relatives, lay people may not understand medical jargons. Okay, so we have to break whatever news that we have, as we see in the previous slide. Maybe patient is going into palliative care, or maybe death of a patient, or maybe any adverse events. So all these things, when we discuss with the patients or with their family members, we need to use this form of communication. So the communication must be sensitive, empathetic, and obviously inclusive. So next time, if you are kind of confused what is enhanced communication, just go back to this example of how we broke the news of our maths, some of our maths course to our parents. So again, what is important in enhanced communications? Firstly, to identify the situation where it is required. Okay, so that has already been discussed. It should obviously be initiated by the primary consultant. Okay, so they are the best people to break the news initially to the family. Okay, because they will have the expertise and they will have the experience as to how to handle the situation. Of course, it's always teamwork whenever we are in hospital. So hospital always includes a team. So the team should include obviously members like a senior nurse, maybe the nurse in charge, or even an intensivist. It should be done, very important next point, it should be done in a private discussion room. Please do not discuss, okay, we always say this, do not discuss patient conditions in the lift, in the canteen, corridors, no. Okay, so anytime you are breaking any bad news to the relatives, okay, or any form of enhanced communication you want to do, it should always be done in a separate private discussion rooms, which each ICU and department ward should have. And if possible, there should be some form of audiovisual record room. Okay, so later on, the family members should not, go back on their word, okay, that they weren't informed about anything. Then obviously assess the family's level of knowledge, as I said in the example, and very gently and unambiguously break the news to the family members. This again, I've made it more detailed. Okay, in the next slide, I'll be showing this to you. So one of the communication strategies that we can use to use enhanced communication or to break bad news, okay, you all can use this also in your personal lives if you want, is spikes. So what are spikes? First is obviously just go back to just reflect on the example that I just told you. Okay, so first is S, that is setting up. So you set up the situation, okay, you understand the area, okay, a private room obviously. Okay, then perception is, that is, you try to understand what are the relatives' knowledge or what is their understanding of the situation and their understanding of the patient's condition. So based on that, you have a base on which you can provide further communication or provide further news to the family members. You have to invite to give information, just like in the example, how we tell mommy, I want to tell you something. Okay, so is it okay? Is it the right time to tell you something? Okay, I want to tell you something serious. So again, invite to give information and then you provide the knowledge. So again, very important is to be factual. Do not put our own assumptions, okay, into this. Whatever points we need to communicate, whatever bad news we need to break to the patients or their relatives, we need to be very factual and unambiguous. And E is exploring and sympathize. So again, we understand how the patient or the relatives, how the relatives taken that news. We can help them to, we can empathize with them, help them to understand the situation. Okay, so over here also nurse is very, very important to deal with the relatives' emotions and to help them out. And last is obviously from the situation, we need to go ahead. So obviously strategy and summarize and just have plans as to how to go ahead with whatever point we are stuck at. Okay, so this spikes we can use definitely for enhanced communication. One more communication strategy that we have over here with us is leap. This can be used for aggressive patients. So again, I'm pretty sure we've all come across aggressive patients at some point in our working lives. So one of the best strategies to use to communicate with such patients or relatives is LEAP. So what does LEAP stand for? First is listen, very important. Okay, rather than just arguing or debating with the person in front of you, You just need to listen out what they are saying. Okay. Second is empathize. Okay. Two very simple things. Two very simple questions. What I use always is, excuse me, I'm so sorry. Okay. What is your issue or what is your problem first? And second is, how can I help you? When you ask these two questions, what is your problem and how can I help you? I think anybody in front kind of automatically calms down by 50%. And then a conversation or a dialogue can take place between the two parties. So first is obviously listen. Second is empathize. Third is apologize. Okay. So apologize for whatever the situation has arisen. And then obviously very important is last P, that is provide solutions. Okay. So these are two of the strategies. First is spikes. Okay. Don't forget this. That can be used in any situations where you need to break bad news to patients or relatives. And second is leap, again, which we can use to deal with basically aggressive patients. So I'm pretty sure, I hope it was a pretty short session. And as I said, it wasn't the hardcore session. It was a very light, simple session. But again, as I said, communication is a very important glue that keeps all our skills and everything together. And we, being the fulcrum of the entire hospital, we need to have optimal communication strategies and optimal communication skills in order to keep the healthcare team members and the patients on par with our treatment. So with that, I'm done with the topic, and thank you so much.
So wonderful presentation, sir. So you have discussed communication, challenges in communicating with the patients, family, and family communication chart, especially awesome. Artificial intelligence, that is eye control, and communication forms and spikes, communication strategies, especially in LEAP. So definitely the participants would have learned many things from you. They may communicate those things to the patient or family when they are dealing. Thank you very much. So thanks a lot.
Thank you, ma'am.
So dear participants, take a deep breath. Knowledge is power. Here, Jyoti Clara ma'am, chairperson, CCNS Tamil Nadu chapter, and Annie Easy member is going to conduct quiz along with Hannah, corporate nurse manager, Angels Global Publicity. Welcome you, ma'am.
What a mind-blowing sessions, huh?
Yes, ma'am.
Very carefully thought topics, wonderfully presented. Hats off to all the speakers and thank you for the participants. You have stayed so long. We are just closing in few minutes. Over to Hannah.
Thank you, ma'am. Dear delegates, we have had a power-packed learning session, so let's get geared up to take up an online quiz. Kindly scan the QR code that is visible on the screen and type your name to join in for the interactive online quiz. So we've nearly had 200 plus delegates join in, so at least we'll have half the members join in, or 75%. Yes, we have Shabana. Thank you for joining in. Delegates, please scan the QR code, or you can go into slido.com and enter 4428988, and you can join in by typing in your name. So we have Meena, we have Maya, Shiny, Prema, Pushpa, Anusha, thank you. It's so encouraging to see many names. Come on, scan in the QR code. If not, please put slido.com in the browser and type in the code that is present over here. You would join into the app to participate in the quiz. Yeah, we have Prema, we have Suvarna, Meena, Jyoti. So we have 17 on board. Can we have at least a minimum of 50? Then we could begin our quiz. Wow, we have a lot of participants joining in. We have Shambhavi, we have Nidhi, Josephine, another Anusha. So we have 26. Come on, delegates, requesting you to actively participate. Come on. If there's somebody, if you're in classroom, please tell the person next by to you to join in. Yeah, we have 36, 37. We are 40, another 10 more, and we would begin the quiz. Yeah, 43. We have Rohi, Bobby, Brinda, Geeta, Amanda, Kavyan, Jagriti, Sneha. Yeah, we are at 47. Another few more members, and then we would begin the quiz. Kavita, Padmapriya, Lavanya. Yeah, since we are at 50, we'd begin the quiz. Members who'd like to join, kindly join in the next 1 or 2 minutes.
Hannah, how many of them are there, Hannah?
We have 52 on board, ma'am. Can we begin?
Yes, dear, we are
Okay.
getting ready.
Okay. So we'd begin the quiz. The mode of ventilation, which is used for patients who can initiate a breath but who have weak respiratory muscles, is dash. Participants, kindly click on to the options that are available and save your options, and we will be seeing the leader dashboard very quickly. We have only 8 seconds, 7, 6, 5, 4, 3, 2, and there you go. So we have majority of our participants given the right answer. So the end of first question, we have Maya on the leader dashboard, followed by Amanda, Ashwini, and Sharon. We'll move on to our second question. Enhanced communication should be initiated by the junior nurse, nurse in charge, RMO, or the primary consultant. We are at 19 seconds, 18. The clock is ticking away, requesting you to give in the most appropriate answer that would fit in for the particular question. We've heard enough from Mario on this topic. So we are 3, 2, 1, and there you go. So we have majority of our participants given the correct answer. That is the primary concern. Then we are at the third question. The nurse ensures that the following drug is administered first when the patient is on controlled mandatory ventilation: analgesics, sedatives, antibiotics, paralyzing agents. So we have less time. The clock is ticking away. We are at 6, 5, 3, 2, and 1. So sedatives is the right answer when we have 50% of our participants given the right answer. The next question, which of the following settings should a nurse monitor when the patient is on pressure control ventilation? So we have 4 options available. Participants, please click on to the right options. So we have 5, 4, 3, 2, and 1. Yeah, we have majority of our participants given the right answer. We go on to the fifth question. Enhanced communication is mostly used in all these situations except handling adverse events, handling aggressive patients, breaking bad news, and discharge process. Three, 2, and 1. And we will see the right answer. We have majority of our participants click on discharge process, which is the right answer. Going on to our sixth question, the following are the methods of communication used for intubated patient except gestures, display charts, verbal communication, written messages. Think well before you answer. So we are coming to the end of the sixth question. Yeah, 3, 2, and 1. Let's have a look. We have 30% of our participants answer it rightly. That is verbal communication. What is the full form of HEPA? HEPA. Is it high efficiency particulate air, high efficiency pressure air, high effluent particulate air condition, or none of the above? Think well before you answer. And here we are at the end of 7 question, 2 and 1. So we have majority of our participants answer it rightly, that is 63%, and it is high efficiency particulate air. What is bundle care approach? Is it collection of evidence-based intervention or best practices or practical solution or collection of correct practices? Participants, please click on to the right answer. We are at the end of the question. 5, 4, 3, 2, and 1. So 81% collection of evidence-based interventions is the right answer. What is the normal pulse range? This must be the tip of everybody. What is the normal pulse range? Is it 80 to 100, 60 to 100, 70 to 80, or 60 to 80? Three, 2, and 1. And we have 38% answer it rightly. We move on to the next question. Which of the following is an indication for control mandatory ventilation? Is it pulmonary edema? Is it myasthenia gravis? Is it apnea or Guillain-Barré syndrome? So we are at the end. 5, 4, 3, 2, and 1. So we have nearly 45% of our participants answer these questions. Congratulations. And we are at the 11th question. What is the lowest and highest score on the Glasgow Coma scale? This must be a really easy question. So is it 0 and 12 or 1 and 15, 3 and 15, or 0 and 15? So we have come to the end. 5, 4, 3, and 2, and 1. Hopefully, many of you should have got it right. Yes, we have 88% of our participants answer this question correctly. It's 3 and 15. This is the last question. What is the minimum air changes per hour in the ICU? Is it greater than 12, lesser than 12 air exchange, greater than 6, or lesser than 6? So 5, 4, 3, 2, and 1. We have greater than 12 and we have only 18%. So we have the dashboard. We have Geeta on the first place, followed by Maya. And we have Helen on the third place, followed by Bindu and Usha as the runner-ups. We'll give them a round of an applause. Thank you, team, for actively participating and enjoying the slido.com quiz that we had. Over to Dana, ma'am, please.
Dana? Thank you, participants. It was great having so many people participate in the quiz. I'm sure it was interesting to each one of you. We come to the end, and I invite Dr. Rachel, the State Vice President, Annie, to give the vote of thanks and also give information on the feedback link, which is on the group.
Good evening to all the participants. Hope it was an enriching afternoon where you had updated and uploaded yourself with power-packed messages which were given by eminent speakers. Dear participants, very few of you are on board. So kindly fill up your feedback forms so that you will get your certificates. Does anyone in the group want to share verbal feedback? You are given a minute for doing that. Anybody wants to unmute and say something, or do you have any doubts which you want to clarify? Right. Since nobody is having any doubts, I'm sure each of the participants have gained your knowledge from the information given, which was very clear, and the PowerPoints also was very clear. So I hope you had a very good knowledge enrichment. I, on behalf of the Annie Tamil Nadu chapter, take it as a privilege, along with the Critical Care Nurses Society, who decided to hold a series of critical care nursing programs. So this was the series 1, which was organized and hosted by Mehta Multi-Speciality Hospital, Chennai. At this time, I would like to thank each of the speakers who took time to prepare the content and deliver it in a very simple, at the same time, very clear messages were passed on. I'm sure all the speakers who were present this afternoon did a great job of presenting the content very well to the gathering. So I thank Mrs. Chitra M. Nayak for talking about monitoring of ICU patients, and Ms. Mary Jansi on understanding the modes of ventilator and the role of nurses, and Ms. Ashwati on infection prevention practices in ICU. And the last speaker was Mario, who spoke well on the communications with ICU patients and their attendants. Each of the speakers took so much of effort in delivering the content. I thank each and every one of you for doing that. I also thank the backbone of this program, Dr. Jyoti Clara Michael, who's the chairperson of the Critical Care Nursing Society of Tamil Nadu chapter, and the Annie founder member, who is the mastermind behind today's program. I thank you, ma'am, for giving your time and inputs on this program. I also thank Ms. Leena Chandrasekharan, who is the president of the Annie Tamil Nadu chapter, for organizing and putting all together the speakers and the content, and every small details of today's success was behind Ms. Leena's effort, which she had put in. Thank you, Ms. Leena, for that. And I also thank Ms. Hannah, the corporate nurse manager, for organizing the Slido quiz program. Good number of participants had taken part in this program. I thank you so much. I will fail in my duty if I do not thank the national president of ANI, Captain Ajita Nair, and the national president of CCNS, that is Ms. Minimol, for giving your valuable time and inputs, and for helping us to complete the series one successfully. This is not an end. You will have a couple of programs going on in series. So what would be your next choice? Also, you can very well put up in the chat box or contact us so that the next series will come forward. I thank each and every one of the participants, either from the hospital side or from the college. And I know some of the areas you were connected as a group. I thank each and every organization for taking time and interest in learning more and updating yourself. Thank you so much.
Thank you, Rachel. Thank you, Hannah. Thank you all the Tamil Nadu officials of ANI. Wonderfully articulated and well-organized program. Thank you, Metas. The second series is going to be on critical care skillathon. So stay tuned and we will come back again soon. Thank you very much.
I hope all the participants have filled the feedback form. Kindly take up the link, take time to fill up so that you will get your certificates. Thank you so much.
Thank you, Rachel ma'am. Thank you so much, ma'am. There was
Thank
no
you.
one. Thank you. So ma'am was helping us out in creating the Zoom link, and she's also deputed one of her staff, Ms. Shiny. Thanks to Ms. Shiny as well for helping us out throughout this program. Thank you so much, ma'am. Thank you, participants, and wish you all join back for the next series.
I'm closing the link. Thank you.
Thank you, ma'am.